All right, so have you covered any ortho stuff or pain management things? Okay, good. So you're familiar with most of your pain medications you're going to see being used. Opioids, have you covered that at all? No? Okay. So there's not a ton of like ortho drugs specifically. We'll talk a little bit about like some stuff at the end here, but this is like kind of my big opportunity to talk about pain management, which is something that you guys are going to deal with on a pretty routine basis when you're out there. And so because a lot of ortho stuff does involve a lot of pain, so there's a lot of pain meds associated with that. So a lot of this stuff will not be ortho specific, but you'll find a lot of it's used in conjunction with that. So anyway, so pain management. So a lot of people experience pain. It's a very common reason for people to present. And you guys know how to assess for pain in a patient, correct? You learned how to. Hmm? How would you assess for a patient's pain? On a pain scale? Okay, so how would you ask someone? Okay. You can show them the faces. Say, okay, what does your face look like? You know, your pain, if you had a face, what it looked like. What other ways could you do it?
Describe it.
Okay, good. Yep, so good. So you can actually, part of your physical exam, you're going to be assessing that as well. I'm not going to cover that super in depth because you guys, that's what you cover in other classes. So I'm just going to kind of get some baselines here, and then we'll talk about the actual medications we're going to use. There's a lot of barriers to appropriate pain management, though. So what do you think are some barriers to people getting the appropriate type of getting their pain under control? Hmm? Okay, yeah. Yeah, sure. Okay, so your first point, things like physical therapy, like who likes to do physical therapy and have chronic back pain or chronic, knee pain, things like that. Like they don't want to do it. It's hard work. It hurts. So yeah, absolutely, non-compliance is a huge issue with that, and which we know it's very effective. And if they stick with that in conjunction with pharmacologic measures, they tend to be synergistic in nature. Another thing, patients don't want to become addicted. They're thinking, oh, that stuff will get me addicted. I'm not going to get on it, right? So that's certainly one concern. Any other barriers you could think of? Cost could be a big thing, absolutely. How about from a provider standpoint to provide good pain management? Yeah, how can you tell if a patient's drug seeking or not? Maybe it has some history. Yeah, so if there's obvious stuff in there, like if in their chart it says patient is drug seeking, do not give them opioids, like that could be one big red flag. What if you're just talking to a patient for the first time? New patient. Yeah, we'll talk about e-force briefly. Yeah, there's another means we could do that. So we'll mention that. But in general, these patients they can be pretty good at lying, right? So in fact, you have patients that complain of kidney stones. They'll prick their finger and put blood into their urinalysis, right? So that way it looks like they actually have kidney stones when really they're just drug seeking. You'll find all sorts of things patients will do, and that can be one barrier from a provider standpoint. If you feel like someone's drug seeking, and is everyone here 100% good judge of character? No, everyone's fallible, right? So again, you may find someone who looks like they're drug seeking, but maybe they're not. So we'll talk about some issues associated with that. Any other issues from a provider standpoint? Mm-hmm. Yeah, so again, a lot of providers don't get specialized training in pain management, and people go to do whole residencies for this. People do whole fellowships regarding pain management, and so it's something that not a lot of people get a lot of training in, but you're still expected to do it, and so that could be one thing. There's also things about fear from like governmental regulation, like you worry about, Florida was, a big deal for the OxyContin Express. Have you guys heard of that? What is that? Yep. Yeah, so people, especially like places like West Virginia and things like that, in Kentucky, they would drive down here in a bus, have a bus full of people, come down to these pain management places where they were giving out, kind of frivolous prescriptions for huge amounts of opioids. They would have certain pharmacies they were kind of in cahoots with that they would fill these illegitimate prescriptions, and they would take them back up and sell them. I just saw something not too recently that said, like, I think in a 2-year period, they'd sent like 500 million pain pills to this one town of like 400 people. Like, so the opioid epidemic is absolutely insane. Nowadays here in Florida, we've cracked down on a lot of that, right? We've cracked down on a lot of those pill mills. A lot of people went to jail for this sort of stuff. And so a lot of people are fearful to write for too many opioids because you fear that, the DA is going to come looking for you and say, well, why are you giving out so many opioids, huh? And so that is, again, another, so there's lots of barriers here to patients getting kind of the appropriate management of their pain. But we know that the worse someone's pain is managed, the more likely they are to self-medicate, the more likely they are to do things like take medications more often than they should. And then that's when you worry about things like addiction. A lot of times these addictions are started not necessarily in looking for euphoria from these drugs, but because they're trying to get their pain under control. And so that's going to be a really important thing here, is that you want to get their pain under control as best you can, because that will help to mitigate a lot of these kind of risks. Anyway, let's see. So understanding pain, is pain an objective sort of thing? Can you objectively measure someone's pain? No. Everyone's pain is very personal, it's very unique, and you can't sit there and deny that someone's in pain, even though they look like they're just sitting here like you or me, right? You guys were in a lot of pain probably during that test, but I couldn't tell necessarily. It wasn't like you were crying. Well, I didn't see anyone crying. They had those barriers up, so maybe just couldn't see it. But these are things where you're not going to be able to necessarily assess this. And you can have patients with chronic pain issues, and you ask them like, "What's your pain on a scale of 1 out of 10?" They're like, "I'm at a 9 right now." And you're like, "Well, you're just sitting there quietly. You're not sweating. Your heart rate's not up. Your blood pressure's not up." But when you've been at it for that long, like that can be just normal for them. And that's that's one of those things. You can't really deny anyone that they have pain. If you ever come up with a way to objectively measure it, you're going to be a gazillionaire, because it's going to fix all these issues. But unfortunately, we don't have that. So pain is really whatever the patient says it is. And so trying to identify, are they having an acute pain issue, or is this more of a chronic issue, is really important in regards to what kind of pharmacotherapy we're going to focus on here. We're really going to focus on things like the etiology of the pain, because this will actually influence what type of drugs we're going to use. So we'll talk about neuropathic pain being very different in nature and in treatment compared to things like somatic or visceral pain. Have you guys heard of these kind of delineations? So what would be like a neuropathic pain? Yeah, diabetic neuropathies that can develop. How would you describe that pain? Burning, stinging, these kind of paresthesias. Yeah, so very different, and we'll see that the drugs are very different in treating that versus something like a somatic or a visceral pain, like someone with appendicitis, is going to require different drugs than someone who has a diabetic neuropathy, right? So we'll get into some differences there as far as treatment goes. Again, acute pain, it's going to be lasting, say, hours to weeks potentially, usually caused by some sort of identifiable thing, so whether it be surgery, whether it be trauma, whatever it happens to be. And it's pretty predictable. A patient will get better, right? They will get over whatever injury they have, and the pain will resolve itself. However, with chronic pain, you're going to find that this is not the case. This is going to be, months to years these patients are experiencing pain, and it can be pretty disabling. And so one of the big things we're going to focus on is to try to get the patients more able, to try to get them to be able to perform their activities of daily living in order to help them regain function. That's going to be a big goal there. And are you ever going to be able to eliminate everyone's pain? No, this is not going to be something that is going to be perfect for every patient. A lot of times you have to discuss what your goal is. So if the patient's always an 8 out of 10, you say, well, what's your goal? What would be great for you? And so if I get down to a 4, that would be fantastic, right? I could start to get around, do things better. And that can be a reasonable goal. Getting down to a 0 is never going to be possible for some patients, okay? So again, looking at neuropathic pain going to be described a lot differently than your nociceptive pain, and that'll be important when you're trying to figure out what type of medications use specifically. But again, usually nociceptive pain, more kind of that dull, aching, kind of throbbing pain versus something like a neuropathic pain, which is that shooting, tingling, kind of burning sensation. And I want this a little quick, but this is just kind of the background to make us, so we can talk about the drugs a little bit more specifically. But we know this is a big issue. A lot of quality of life gets impacted by chronic pain, loss of, ability to work certain days. There's a ton of costs associated with this. So the better you can get these patients kind of back up and function, the better off they're going to be overall. So appropriate pain management is contingent on getting good optimal assessment of their pain as well. So we talked about a few ways that we can kind of assess their pain. We talked about certain scales. You mentioned the FACES. Anyone know the name for that? It's the Wong-Baker FACES scale. We use that for what type of patients? Use it in pediatrics, right? Because if you're talking to a 2-year-old, you say, what's your pain on a scale from 0 to 10, 10 being the worst pain you've ever experienced? And they're like, well, I stubbed my toe last week. Like, that's probably the worst I've ever experienced. They can't really understand that, right? So you have to kind of put it into terms that they can understand. Who else might have a hard time dealing, using scales like a 0 to 10 sort of scale? The elderly, yeah. So especially if they have any cognitive decline, and we'll see some examples of scales we can use for them as well. Anyway, you guys know about assessing patients, doing the physical, trying to get an idea of where's the location of the pain, what's the onset, the duration, what's making it better, what's making it worse. You guys are familiar with already asking these sorts of questions. And again, asking those descriptions of how does the pain feel for you can give you an idea. Is this more of a neuropathic issue? Is it somatic? What could it be? And so, again, asking a patient, on a scale of 0 to 10, what's your pain right now? 10 being the absolute worst pain you've ever experienced. And you'll ask patients that, and it'll be like, they'll just be sitting there quietly. It's an acute pain issue. They're coming in for a migraine or something. You're like, it's a 10 out of 10. I'm like, okay, so a 10's like I'm chopping your arm off with a rusty spoon, and you're at a 10 right now. And they're like, yeah, I'm at a 10. It's like, okay. and again, sometimes you have to kind of take things with a grain of salt. Some people may kind of play up things a little bit. There's a really funny comedian, you guys can probably Google it. The guy was going into the ER for some pain issue, and he was like trying to figure out what number to tell the nurse that he can get. He didn't want them to think that he was pain seeking, so he didn't want to say a 10 out of 10. But he also wanted to make sure he actually got some medication for his pain, so he didn't want to go too low. So he was trying to find the sweet spot. I think like he settled on a 7. 7 was the right number to tell them to get the right medications that he's hoping to get treated for. But anyway. So again, you also ask about things like, mild, moderate, severe, different ways to describe the pain can be useful. And the reason why we do this is so we can look for the pre and the post. We don't want to look for that delta there to see kind of how things are changing. So you ask them right now, they say, hey, I got my 10 out of 10. You give them a dose of morphine, come back 15 minutes. How do you feel now? Okay, I'm an 8, right? So it tells you objectively, at least in some ways, that their pain is getting improved, right? At least from the patient perspective. So here's another a visual analog scale that you can use. Notice here there's no number. So basically you'd have the patient kind of point to where they feel like their pain is at. The nice thing here is you don't have patients able to really game the system because they can't really say, oh, I'm 9.3 centimeters. They're just kind of pointing at it, right? And so it kind of gives you a little bit better way for them to not try to just stick with a certain number. And like, my wife, she, she's a pharmacist and she did her residency in pain management at the VA. And so doing a lot of those vets, like they get very, very tied to their pain number, right? So, these old vets would be like, I'm a 6, I'm always a 6. And you kind of try to tune up their drugs, come back the next day, how are you feeling? It's like, oh, I feel much better, I feel 100% better. What's your pain on a scale of 0 to 10? I'm still 6. Right? For whatever reason, psychologically, you just get tied to that number because that's their pain. And that's okay, and so you have to look for other markers. You have to look for other things where these scales can be useful there. I mentioned that Long-Baker scale, using something like a thermometer sort of scale can be good. I mean, you guys being relatively young, has any of you actually seen a thermometer that actually looks like that? Like an old mercury thermometer? Probably not many of you. Probably it gets fewer and fewer every year. But a lot of older patients are going to at least be familiar with that. They can say, okay, well, how would you rate your pain on this kind of thermometer? It's better if they have more, even the faces work for them, especially if they're having kind of more cognitive decline. That's reasonable. So again, always want to kind of figure out what is making it worse, what's making it better, especially focus on what medication treatment they've been trying to use themselves, if they're self-medicating, figure out what other pain medications they've responded to well in the past, if it's a chronic pain issue, and we see this a lot in peds when we have these sickle cell patients, right? You guys familiar with sickle cell disease? What is that? Yeah, basically the red blood cells get this kind of sickle shape, and they get kind of sludgy, and they get kind of stuck in the veins in our arteries, and so they will have a lot of acute pain crises, especially like acute chest pain associated with sickle cell disease. They come in very frequently for these, and so it's important to know like, well, what works for them? Because if they come in, several times a year to the ER for these sickle cell crises, and they don't respond well to morphine, and you try to give them morphine, they're going like, well, what the heck are you doing? Like, that doesn't work for me. Maybe Dilaudid works better for them. Maybe fentanyl works better for them. And so it's important to understand kind of what they've tried, what doesn't work for them so well, so you can try to go with something a little bit better. And so that's a big thing. Focus on the medications they've already used prior to coming in. So especially if you're like in an urgent care, emergency room setting, like figure out what they already took beforehand. So if they took a big full dose of ibuprofen 15 minutes before they got to the ER, chances are you don't want to give them more NSAIDs, right? So that's important to figure out from the kind of the recent history as well. Look at things like organ function. It's going to be important for certain meds, especially like with elderly patients with these chronic pain issues. If they have poor renal function, they can accumulate drugs. They can get those levels really high for certain things, which can be problematic for them. We see seizures develop if they're not clearing drugs appropriately. So focus on things like that. Look for history of substance abuse. You're going to find there's certain non-controlled substance we may be able to manage patients on. But in some cases, you may have to give persons with a substance abuse history opioids because that may be the best thing for their pain. So we'll look at some ways to get around that. And of course, especially with chronic pain issues, there's a lot of depression that goes along with that, a lot of anxiety that goes along with that. So kind of focus on them from a psychosocial standpoint as well. A lot of times they need some sort of therapy for there are other issues as well to kind of help them manage the pain, especially if you have things like neuropathic pains. We'll see the SNRIs are going to be a good set of drugs you can use for that. And if they have concomitant depression, guess what? You can just kill 2 birds with 1 stone. So that may be a good option for someone like that versus just using a straight SSRI, which is not going to be as good. And we'll get into those a little bit later. So anyway, so imagine especially patients with chronic pain that, they're going to have a certain baseline level of pain that's happening kind of throughout the day. This is 24/7 for a lot of these patients, and they're going to have these little spikes that happen here. And so it's important when you're managing these patients that you want to have medications both for the kind of the basal pain they're experiencing, and then you also want to have things for breakthrough pain, right? So this is why in a lot of patients you may see them being on extended release oxycodone plus an immediate release oxycodone. And it makes clinical sense because they can take the extended release product scheduled throughout the day. Maybe they take OxyContin, say Q8 hours, to try to get them managed throughout the day. You can see this blue line here, and then they'll be on something like an immediate release oxycodone that they can take, say, every 4 to 6 hours as needed for breakthrough pain, right? That would be how you'd write that prescription, say for breakthrough pain, and then they would take something basically only when they experience that additional pain. If you kind of don't manage this kind of basal pain, or you don't give them something for the breakthrough, this is when they start to self-medicate, and you may see them start to utilize more oxycodone extended release, not realizing that when you start to dose stack those, the levels start to go pretty high, and those levels are going to stay around for a while, and that's when they can run into some big issues. We'll talk about adverse effects a little bit later. So, let's see. Of course, pictures. Well, this thing doesn't like pictures. Any questions so far while my PowerPoint tries to catch up with me? All right. So there's a couple of ways we can go about treatment for these patients. So you guys heard of the WHO? Not the British rock band, but the World Health Organization. So they have this ladder approach to treatment we'll see here in just a second. And there's also kind of an etiology-based approach. So for instance, if a patient has migraines, treat them like they have a migraine. Like look at your triptans, look at your ergots, things like that. Treat them based on the etiology of their pain, not necessarily just like you would, kind of a blanket way of treating all pains, right? But the way we do the WHO ladder approach is going to be basically you have this kind of step one where you're kind of using the wimpiest of the pain medications. What do you think kind of falls into this category here? NSAIDs for sure. Acetaminophen, yeah, those are the big ones, right? Non-opioid medications in general are going to be for the kind of the first step, right? So you want to start with that because again, you want to think of yourselves kind of like a magician. Like, do you always like start off with a showstopper? No, you start with like pulling the rabbit out of the hat before you start chopping your assistant in half, right? So you gotta start low and then gradually work your way up based on their pain. This is where you can start to, and you get to step 2, more mild to moderate pain. This is where you're going to get more into potentially, opioid therapy, oral opioid therapy. Maybe you start to see things like, parenteral NSAIDs starting to be used here, a little bit bigger guns essentially. And then for the kind of the worst pain, here's where you definitely get into opioid management, definitely into some parenteral opioids, as we'll see some options here in a second. Now, the question is, do you always have to start at step 1? Right, so if someone came in and they have an obviously deformed fracture, do you want to say, here's some Tylenol, let me know how you feel in 15 minutes? No, you want to go ahead and give them some fentanyl. You want something to knock down that pain initially because you want to get them under control, and then you can see if you can scale back essentially. So it's okay to start with step 3 if they have an obvious reason for their pain, but in general, you always can give more drugs. You can't necessarily take it back. So always keep that in mind. Again, that misconception, you don't have to go step by step. You can jump around a little bit, but in general, if it's more mild pain, start off with something non-opioid. Work your way up if you need to. Okay, so we'll talk about some different ways we can manage pain. The first one we see is, especially like with injuries, is there's going to be a process of inflammation that happens. Imagine you cut yourself, you have a car accident, you have some sort of physical trauma. There's usually inflammations happening at the site, right? And so we're going to see things like serotonin start to be released, histamine starting to be released at the site, and along with a lot of prostaglandins being made. So can you start to see what medication we might use to manage this, especially prostaglandin synthesis? What produces prostaglandins? What enzyme? Cyclo-oxygenase, right? What blocks the activity of cyclo-oxygenase? NSAIDs, yeah. So you're going to start to see that, especially when you're dealing with inflammation, NSAIDs are going to be a really good drug to help to manage that at the local site. Acetaminophen is not going to be good as an anti-inflammatory, but the NSAIDs are going to be better for that. And so you're going to see when you have all this kind of inflammation starting, you're going to be recruiting a lot of inflammatory cells that are going to be migrating to that site. And so you can try to mitigate that a little bit with using things like NSAIDs. That's going to be beneficial. And so we're going to see there's a lot of stimulation that happens. These pain fibers tend to be sensitized when you have that inflammation happening. So by inhibiting that, you help to leave those nerves less likely to send those pain signals. I'll show you some pictures of that in just a second. But the big thing is going to be those prostaglandins we're going to be targeting at that local site. So imagine here, you have your site of tissue injury, someone cut themselves. They're going to have these nerves that are going to be sensitized by things like your histamine, by things like your prostaglandins, and those signals are going to get sent up through the spinal cord up into the CNS. So there's several places we can intervene here. We're going to find that things like NSAIDs are good to inhibit that inflammation right at the site of injury. That's good. Anyone know what you could do to block this actual transmission of the signal to the spinal cord? So this is where things like local anesthetics are going to be really useful. So we can use things that, you guys remember we talked about lidocaine back in the antiarrhythmic section? That's a really good local anesthetic. You remember how that one worked? It was a sodium channel blocker, if you remember. So by blocking sodium channels, you prevent propagation of that action potential. So I can actually inject lidocaine right here at the site of the nerves, and that will actually deaden those nerves and that pain signal. Even though that site may still be inflamed and it may still be painful, the patient's not going to experience that because the signal never gets to the CNS. That's one way we can do it. And that's where a lot of pain blocks are starting to be used nowadays, especially like in a post-operative setting where I can inject local anesthetics directly to the site, deaden all those nerves, and that way the patient doesn't experience pain. They're using a lot less opioids than they would have to otherwise, right? So that's one way we can do things. You're going to find that the opioids are going to be primarily working here in the spinal cord. So we'll look at those in just a few minutes. And then we'll also see some activity here in the CNS for the opioids. So those are kind of the big places we can try to intervene and deal with those pain issues. So again, by inhibiting prostaglandin synthesis with our NSAIDs, we're going to be able to do things like block that permeability. So hopefully you're going to get less edematous, less leukocyte migration, less sensitization of those pain fibers. So you'll find that these agents, especially like NSAIDs or acetaminophen, are going to be good for mild to moderate pain. If you're really having kind of more severe pain, we're going to have to go with bigger guns. They can be useful as an adjuvant, right? We can use them in combination with other kind of bigger analgesic type drugs, but these are only really good by themselves for mild to more moderate pain, right? So I mentioned cyclo-oxygenase being inhibited here to inhibit prostaglandin synthesis. Remember, we talked about which agent is irreversible in its inhibition of cyclo-oxygenase. Use it for cardioprotection. Aspirin, yeah, remember aspirin. We can consider aspirin a non-steroidal anti-inflammatory drug, right? It's a non-steroid, it's an anti-inflammatory drug. That's an NSAID. That one's irreversible. Remember what impact that had on adverse effects? Your bleeding risk is going to be higher because once you irreversibly inhibit that platelet, you're not going to be able to have that platelet really work from a clotting standpoint. That's why we use it as a cardioprotectant. However, with other NSAIDs, you get some transitory bleeding effects. However, once that drug's out of the system, the enzyme is able to function again. You don't really see that. Once the drug's gone, you can start to clot again. So that'll be important when we're looking at some of the side effect profiles here. The other big thing, we've kind of talked about this during the GI section, is that we have COX-1 that's going to be that constitutive form of the enzyme that's always being expressed, and that's really important in the stomach. For what reason? Why do we like prostaglandins in the stomach? So remember, when we give NSAIDs, we're blocking prostaglandin synthesis, and that actually will help to degrade that gastric barrier, right? Remember, our stomach acid normally does not chew through our stomach lining because we have that nice mucosal layer. We have that nice bicarbonate sort of layer that helps to buffer that. When you have prostaglandins being inhibited by blocking cyclo-oxygenase 1, you lose that, and that's where you can see NSAID-induced ulcers. Remember, it's one of the biggest reasons for stomach ulcers, H. pylori and NSAIDs. And so this is a big deal here, and so we're going to look at some drugs that are going to be more COX-2 selective, and that will help to limit that effect on the stomach. So it's important if you have a history of a patient with the GI ulcers, COX-2 selective agents can be better for them. So we'll look at some available agents to do that. So looking at the etiology kind of based pain, we're going to see that with somatic and visceral pain, NSAIDs are good for this. Acetaminophen is going to be good for this, and corticosteroids in some cases, right? So we saw a lot of pain conditions already we're managing with corticosteroids. Opioids are then going to be used as well as an adjuvant for that, right? If you're doing more neuropathic pain, we'll get to this later, but this is where antidepressants, anticonvulsants, and even drugs like Diclofenac and other muscle relaxants are going to be better for that neuropathic pain. They may still require some opioids, but in general, you try to avoid those for neuropathic pain because they don't tend to have the same sort of efficacy as for someone who has a fracture or someone who has appendicitis or something like that. So kind of keep these delineations in mind, because I might ask you on a test question, what's the best first option for this patient? They have a fracture. Should you give them an antidepressant? Probably not. It's probably not going to be the best stop for them. They might be depressed for other reasons, but it's not going to fix the fact that their arm's hurting because it's broken, right? So again, really super important to make sure we try to focus on those non-pharmacologic therapies. Again, physical therapy is super, super important, but a lot of patients are not compliant with it because it hurts, it's too much work, etc. They'd rather just take a pill and have their pain managed, but it's not always going to be best for them. So try to focus on that, focus on the psychological aspects of it as well. And our goals here, again, we may not be able to eliminate pain, but if we can at least get it under control, help them to kind of regain their function, it's going to be best for them, and it's important to have that conversation to make sure goals are lining up between you and the patient. Okay, so again, we want to make sure we're individualizing that treatment based on the type, severity, patient history, so kind of looking at all aspects there. And just remember that everyone's going to respond a little bit differently to these medications. Not everyone's opioid receptors are the same. Not everyone's cyclo-oxygenase is going to be the same. There's some variability there. So just because someone fails ibuprofen doesn't mean that Meloxicam is a bad drug for them, right? You can try switching between a class. We'll look at those in a minute. Just because someone does bad with morphine does not mean they're going to do poorly with hydromorphone, right? We have some leeway here. We can try different agents within the same class. So looking at our options here, we're going to talk about acetaminophen. We'll look at our NSAIDs, opioids, and then some of the adjuvant therapies. That's kind of the main breakdown of pain meds we're going to look at. So starting off with Tylenol, I know we've mentioned it here before. You guys remember where the name for Tylenol comes from? It's kind of hard to see the bolding here, but you can see this. This is the chemical name for Tylenol. So you get the TYL and the ENOL at the end there. So again, some of these guys may come up with these names are maybe not the most inventive, but that's where it comes from. But anyway, so use acetaminophen. It's good as an analgesic for more mild pain. It's good as an antipyretic, so if they're having fever as well, it can be another good thing, but not really good for dealing with local inflammation, right? So if I have an injury, the acetaminophen is not going to be good for dealing with that inflammation that's happening right there at the site. It may still provide some analgesic effects, but it's not really going to be packing the series of punches something like an ibuprofen might, right? We're going to use this pretty frequently for things like low back pain, osteoarthritis, so very, very commonly used for those conditions, and pretty much it's well tolerated, right? That's why we like acetaminophen, because there's really few like drug interactions you have to worry about, really few toxicities you have to worry about. Which organ toxicity do I want to be careful of with patients who are overusing it, though? The liver, right? So that's one thing you have to be careful of. And again, patients who have chronic pain issues, they might be taking this pretty consistently throughout the day. So what's the maximum amount you don't want to go above? 4 grams, right? So you don't want to go above 4 grams. And patients who have liver disease or history of that, they may actually need to decrease that down to something like 3 grams, because they've seen even patients who are relatively healthy taking 4 grams every single day consistently, you still see some rises in their LFT. So again, Tylenol is not without its dangers. You make sure they're not self-medicating and going above that 4 grams. We have things nowadays, like if you go to the inpatient side in the hospital, we have EMRs that actually will help to block nurses from actually giving too much Tylenol. So for instance, if you're giving hydrocodone / acetaminophen combination product plus acetaminophen outside of that, once they hit the 4 gram mark, it'll actually tell the nurse, hey, they can't receive any more today. So it's nice from that standpoint, but if the patient's doing it themselves, they can get into some trouble there. So they have to take into account every source of acetaminophen they're getting. If they have a cold when they're taking NyQuil, there's probably some acetaminophen in it. If they're taking Lortab, there's probably some acetaminophen in it, in addition to that Tylenol arthritis that they're taking in addition. So they cannot go above that 4 grams because they will run into that liver injury issue, right? We have a good IV form that's available, so you may see this, especially in the surgical world. It's called Opherma, and we're actually seeing that it's good for patients who can't tolerate oral or rectal medications, and then it's good for its opioid sparing effects. And so what do you think I mean when I say opioid sparing? You just have to use less opioids, right? And so in general, when you have patients, especially in the post-op setting, the fewer opioids they're using, the more likely they are to have their bowels start to wake up and be functioning again, the more likely they can get recovered and get out of the hospital, right? Because again, you want to shorten this duration. They have to stay in the hospital as best you can. And so things like Opherma are able to reduce the amount of opioids they need, get them kind of under control a little bit better from a pain standpoint, and they can see things like shortened duration of stay in the hospital, decreased cost, decreased adverse effects because you're using less opioids. That's always a good thing. Who do you think couldn't use oral or rectal Tylenol? Who couldn't use like a rectal administered drug? You know, we talked about certain patients because you worry about infection. Neutropenia, yeah, so patients who are immunocompromised, so think cancer patients, especially they're receiving chemotherapy and they have that stomatitis from their chemo that they're getting and they're neutropenic. You don't want to give them anything orally or anything rectally because you worry about having infection caused, or especially from the rectal standpoint. So that's where things like IV acetaminophen can be really good for them to help get their kind of fever under control. So that's a common place we'll see that being used as well. So again, we don't have the full mechanism for the drug, but the reason why we like it is it has good safety profile for the most part. And again, I mentioned that hepatic necrosis that can happen there. So be very careful. Make sure you're considering all sources. Again, if they're taking acetaminophen 650 Q6 hours, 4 times a day, plus hydrocodone acetaminophen every 4 hours, they can very easily get above that 4 grams. So you gotta be really careful with that, because I've seen a lot of patients who, no fault of their own, they just didn't know any better, get into some big trouble, have to end up on IV Mucomist and stay in the hospital for a couple of days because they put themselves into liver failure. Okay. Up next, we have our NSAIDs. We mentioned that these are good as an analgesic, antipyretic, and anti-inflammatory. These are good in combination with acetaminophen. In a lot of cases, you may, if you don't want to use opioids for a patient, you can have them cycle between acetaminophen and ibuprofen. You may give, say, acetaminophen every 6 hours and then ibuprofen every 6 hours, and you just do one, basically, just cycle them every 3 hours. So do acetaminophen, 3 hours later, the ibuprofen, and doing things like that are helpful to help kind of get that pain under control for, a few day period or something like that. So think about your dosing, how you want to make sure you can cycle those things to try to get best management for your patients. Anywho, again, most of these are going to be non-selective in either inhibiting COX-1 or COX-2s. We're going to see risk with those GI ulcers developing there. I'll talk about a few that are going to be more COX-2 selective. Those are better for high-risk GI patients. Okay. And we mentioned these probably ad nauseum. We talked about them in a ton of other conditions, so I'm not going to go over too much more in detail, except for some specific agents we might not have talked about before. But certainly aspirin's a big thing here. Remember who should not get aspirin? So maybe high-risk GI patients. Who else? Remember children who are post-viral, right? So no one less than 16, especially if they have any history of viral illness lately. And what's been going around pretty big nowadays? The flu, right? Because again, flu vaccine wasn't really up to snuff this year, and so we're seeing a ton of flu being hit. And so a lot of people may try to take acetaminophen because they have fever or aspirin associated with fever there. So again, be very careful with that, because then if you give that to them, what can they develop? Yeah, they get Ray's syndrome, so you want to be careful with that. Anywho, we have a plethora of other NSAIDs we have here. I have a table to show you a few other examples, but ibuprofen, naproxen, these are good because they're available over the counter, available as oral agents. We also have some other ones. You have things like indomethacin, you have tolmetin, you have ketorolac. Most people say Toradol. I'll show that in a second, but that's a good parenteral NSAID. So if you go into especially like an ER or something like that with a pain issue, chances are you're going to get Toradol. So it's a very good opioid-sparing sort of NSAID used in the parenteral route, either IM or IV. So you use very commonly. There's no clear benefit of one over another. If they respond really well to naproxen, that's great. They can be on that one. A lot of times, though, you're going to decide which one to use based on duration of action. So if I have a really chronic pain issue, I want something I don't have to take every single 8 hours, right? I want something I can just take one time a day. So you might choose a drug that has longer duration of action versus something like ibuprofen, which I may have to take every 6 to 8 hours, right? If you look at those Aleve commercials, what are they normally touting as their tagline? It's like all day strong, all day long, or whatever happens to be. But basically, Aleve has a longer duration of action, and so you can take that one just one time a day or twice a day and get a full day's relief versus ibuprofen may take 3 or 4 times a day. So those are things to consider. If it's an acute pain issue, maybe ibuprofen is totally fine from that standpoint for a few days versus if I'm having to take this for months and years because of my chronic back pain, right? So talked about the common side effects. Be careful with the gastric effects there, mainly due to that decreased mucus production, decreased gastric barrier. And the bleeding effects is primarily going to be seen more with aspirin, especially for consistent use because of that irreversible effects it has on the platelets. The other drugs, they'll have a transient effect while this drug is around, but once they're out of the system, they should really go back down to baseline risk for bleeding and bruising, right? Again, be careful with pregnant patients. We mentioned the NSAIDs kind of become more of like a category D sort of drug because of risk of things like closing that ductus arteriosus too early, can delay spontaneous labor, things like that. So we can avoid those in pregnant patients, especially late stage pregnancy. All right. Some patients are going to be more sensitive to this effect than others, but if you have an asthmatic patient and they say they have that ibuprofen allergy or aspirin allergy, chances are it's due to this fact here. So again, if you go back to that picture looking at the different pathways for arachidonic acid, you saw they can go down the cyclo-oxygenase pathway, and then the other one's lipoxygenase. So it goes down that lipoxygenase pathway, it forms leukotrienes, and what do leukotrienes do in the lungs? They bronchoconstrict, right? Remember, think back to asthma. I think when we give Montelukast or Singulair, that's a leukotriene receptor antagonist, right? So it helps to block bronchoconstriction by blocking the activity of leukotrienes. So for someone who's taking ibuprofen, if they're especially sensitive to it, if you shut down that cyclo-oxygenase pathway, it gets shunted over into the lipoxygenase, and they produce more leukotrienes, and that can induce an asthma attack for them. So if they have that allergy, ask them what it is, and they say, oh, I have an asthma attack whenever I get ibuprofen, that's what that mechanism is. It's not an actual true anaphylactic allergy. It's just the fact that they're having more sensitivity to those leukotrienes that are now being upregulated in production. That makes sense? Okay. Again, for the most part, watch out for hepatic function. They may have some accumulation in patients with poor liver function. And then the other big thing to watch out for is going to be the renal effects. So remember, especially patients who are really dependent on those prostaglandins to open up that afferent arteriole in the glomerulus. If you shut that down, you can see an acute decrease and their renal function. So those are elderly patients who have renal disease. Be careful with them because you can affect all sorts of other drugs. You can definitely have a big acute decrease in their renal function. So again, just going over a few specific examples. Remember anywhere else you find salicylates, like an over-the-counter product? Yeah, Pepto-Bismol is the other big one, some of the one to avoid in kids. But if you ever wonder why they call aspirin ASA, it goes back to the name here. So acetyl salicylic acid, so ASA, kind of makes sense there. And again, this is irreversible, non-selective. So again, you worry about those prolonged bleeding effects for the lifetime of those platelets, right? So it takes time for that to kind of cycle out and get new ones made there. So again, as far as contraindications go, it's pretty straightforward here. We already mentioned the Rey syndrome thing. Already mentioned the bleeding disorders. You be careful if they had something like warfarin on board for AFib. You might not want to add on full dose aspirin to deal with these pain issues, right? Those are things to consider there. Now, the other NSAIDs are kind of the more typical ones you think of, like ibuprofen, naproxen. They kind of fall into this category, these propionic acid derivatives. You don't really need to know that name specifically, but that's kind of the chemical classification for them. But in general, you're going to find they have very similar side effects we've already mentioned. The bleeding effects are lessened, and most of these are going to be non-selective, unless I kind of make mention of it being selective. Those would be good ones to remember, because if I ask, if a patient with chronic osteoarthritis, but they also have a history of NSAID-induced ulcer, which agent might be good for them? This is something you might want to be able to kind of hone in on for some of these specific drugs. So I'll mention those in a few minutes here. So obviously we have things like ibuprofen, naproxen, but you have ones, and again, not important to remember these numbers here specifically, but just know this is what influences your decision on which medication to use for them, because again, something like ibuprofen, it only has a half-life of around 2 hours. You're taking it pretty frequently. It's okay for acute pain issues, but not good if someone's going to be taking this for the foreseeable future. You might use something like oxyprosin, which has a 40 to 60 hour half-life. And that one even has in the brand name Daypro, so you only take it one time a day, right? So that could be a good option for them, or something like phenoprofen, ketoprofen. These are all options that are going to have longer durations of action and be given less frequently. Just some other kind of specific ones we'll kind of make mention of here. We have indomethacin. This one is sometimes seen as an IV agent, and we used to use this to close down the ductus arteriosus. So if you had a patient who was born and they did not have closure of that, and they're having issues of, if you guys cover like fetal blood flow, right? So there's some issues there. Once they're actually out and breathing, they need to have that ductus arteriosus closed. Otherwise, they're having inappropriate mixing of the venous and arterial blood. So sometimes we'll actually give them indomethacin, or sometimes there's actually a form of ibuprofen we can actually use to help close that down. If this closed down too early and they have a congenital heart defect where they actually need that mixing, anyone know what we would give them? You can give them prostaglandins. So we actually have a drug called alprostadil, which is a synthetic prostaglandin to keep that open, right? So again, think about the kind of the counterbalance there. Prostaglandins open it up, so we can give that if they need that open, or we can shut it down if we need to give something like an NSAID that will help to decrease prostaglandin synthesis, right? Anyone know what else you would do for a patent ductus arteriosus? Like drugs don't work? Well, if the drugs weren't working, you can just do a surgical ligation. So a lot of times I'll have to go undergo surgery to have that actually closed off physically instead of having to use medication. So again, just something you might see if you ever work with peds cardiac or anything like that. Anywho, again, you're going to see that these are, especially some of these more potent agents like indomethacin, like Toradol, these are good for short-term use because you worry about them having too big of an effect on the GI, a much higher risk for GI ulcers that can develop there. So this one would be good for short-term use, maybe like a week, not good for something that you're going to be taking for months to years. So I mentioned Toradol. This is a really good parenteral medication if you have someone with a migraine coming in or someone with any kind of pain issue, really. If they don't have a contraindication, Toradol is a great drug. We use it almost as frequently as we do Zofran, I would say, in the PTR. So it's a very common drug we use. And again, it's good as an opioid-sparing agent. So if you had someone who you thought was drug-seeking, maybe you can say, well, if I don't want to give them an opioid, maybe I can give them Toradol instead as a good option. A lot of times, though, you'll find these patients may be like, well, I have an allergy to Toradol. I can't receive it. And so you're like, okay, well, now I'm stuck. And they're like, well, I'm allergic to morphine too. The only thing that works for me is Dilaudid. Those are kind of the key things you might want to hone in on and be like, oh, this sounds a little nefarious. This sounds, I don't know if this is legit. It could be legitimate. Don't let me make you cynical, but keep your ears out there. And you never know what the patients are actually trying to get at. Anywho, so this one has a black box warning actually for the GI effects because it is so potent at inhibiting cyclo-oxygenase. You actually don't use it more than 5 days. So it's an important stopping point. And actually, when you put this into a lot of EMRs, you're finding that will actually have an automatic stop date on there so they don't get any more than 5 days because that risk for GI ulcers is going to be too big at that point. Meloxicam, so this is starting to talk about some of the agents that are more selective for COX-2. So Meloxicam or Mobic is good because, again, remember we talked about Vioxx, how that one is like completely selective for COX-2 enzyme versus COX-1. That one actually got pulled off the market because you need some balance between COX-1 and COX-2, because otherwise, if you only affect COX-2, you saw increased risk for cardiovascular death, and that was something that we didn't see until we were giving it to millions of patients. Because when Vioxx came out, it was like a big blockbuster drug. It's like all these patients who couldn't receive NSAIDs because of their GI issues, we can give them Vioxx, and it's great. We gave it to millions of people, and then we said, oh wait, these people are more likely to die from a cardiovascular standpoint. Let's go ahead and pull it off the market. Nowadays, we have drugs that have some selectivity for COX-2, but they still have some balance there. So Meloxicam is one of the first ones here, where it has about a 10-fold selectivity for COX-2, but you don't see the increased risk for cardiovascular death. So that's why we still have it on the market. Well, it's still pretty good. So there's less GI toxicity that helps to mitigate that in history, or patients with a history of bad GI effects. There's also Diclofenac. This one has a little bit of COX-2 selectivity. This one's nice because there's actually a topical formulation that's available. We'll talk about this when we get to, we haven't talked about osteoporosis or osteoarthritis yet. Did we? Did we talk about rheum already? No, I think we'll talk about that later. You need to look at the syllabus, but this will be a good one we'll talk about later on, because you can use this topically, especially for like osteoarthritis, rheumatoid arthritis. If you have a few number of joints being affected, you get nice local effects by applying Voltaren gel right to the site instead of having to take a systemic NSAID. So it's good for some patients. But just be aware this is something that's going to be prescription only. Really, the only NSAIDs you're going to find that are available without a prescription are really going to be aspirin, ibuprofen, and naproxen. Most of the other ones are going to be prescription based. However, if you go to Nassau, if you decide to go on a little 3-day cruise or something, you can actually get Voltaren gel over the counter there. So I remember one time we went, and my wife was very excited. She's like, "I want to buy up all this stuff because I have to usually get a prescription for this." Anyway. So looking at the COX-2 inhibitors, really the only one we have nowadays is going to be Celecoxib or Celebrex. I'm sure you've probably seen some commercials or heard about it before. That one has the most selectivity for COX-2 out of the bunch, and is going to be the best for someone who has a history of GI issues. Again, when reviewing the data, it did not appear to have that same increased risk for death as we saw with things like Vioxx. So it stayed on the market. However, if you have a patient with a high-risk cardiovascular history, this may be one you want to avoid. Maybe just not use an NSAID for those patients and try to manage their pain with something else. So again, keep the cardiovascular history in mind. Keep the GI history in mind. Those are things to consider when trying to use an NSAID for these patients. So again, Celecoxib is going to be Celecoxib is the main one we're going to use here for this category. And again, this is all kind of a scales of gray sort of thing, where like Meloxicam is a little bit more COX-2 selective, Voltaren's a little bit more, but Celecoxib is going to be the most selective for COX-2 out of the bunch. Okay, so any questions on the NSAIDs? We talked about them before, so I figured no point in kind of belaboring the point there. I'm going to get started with the opioids. Do you guys mind if I go to 10? Just 5 more minutes. Okay, we got started late. Anywho, okay. You know what plant that is? It's the poppy plant. This is actually where we get all of our opioids from. So we think heroin, think morphine, think codeine. These are where these agents come from, is actually the poppy plant. And so the big thing to note here is that our opioids, there's a couple of different opioid receptors that we have available in the CNS and in the spinal cord and the brain. The main ones we're going to focus on is the mu receptor. There's also kappa and delta, but we're not going to focus on those for our purposes here. Just focus on the mu receptor. This is where the primary analgesia is going to come from, where the primary euphoria, which is going to be a big issue we're going to run into with that, and then also the respiratory depression, and it's going to be kind of the big safety concern there. It's going to come for those mu receptors. You may see them using some different nomenclature. You may see like OP1, 2, and 3. OP1 is another name for the mu receptor, so if you ever see that, that's what they're kind of referring to. And these are going to be reserved for more moderate to severe pain issues. Right? So imagine you had an injury to the hand. Imagine someone dropped something on there, and then so you're having these pain signals that are being sent up through the spinal cord. And so the first place the opioids are going to affect here are in the dorsal spinal cord. So they're basically going to be blunting that response and mitigating what kind of gets sent up to the CNS. And again, I've not been one to ever do a ton of opioids. I think I got a little bit of Darvocet after having my wisdom teeth taken out, so I don't have a ton of experience with these. But the way someone described it to me, which I thought was good, was that you still know you have pain, you just don't really care about it. Like it really just doesn't. It's not a big issue for you. So the pain's still there. However, that signal is being blunted as it gets sent up in the CNS. There's some mu receptors up here too in the brain, but the primary place is the spinal cord. And this is why when you give things like epidurals, say for someone who's having going into labor, they have fentanyl in there. It's a very common one because they can actually directly affect those receptors right there in the spinal cord, and only affect certain areas of the body based on how high up the drug is going during that. So if you just want to have, someone who's going into labor, just kind of have them numb and have that analgesia basically from kind of the waist down essentially, or a little bit higher than that. That's how you would do that, is by giving that epidural and give very kind of local effects there. That kind of makes sense based on where those mu receptors are. So basically what you're going to find is that this is the main one responsible for the analgesia, the respiratory depression, because again, if someone's going to die from an opioid, it's due to respiratory depression, unless they get very sleepy and crash their car or something. But the main thing you're going to see, if no other kind of intervening factors happen, is the respiratory depression, but also the euphoria. And again, this is why we worry about things like addiction happening with these drugs, because it is people use this for the euphoria effects. They use it for the high they get from these medications. Again, kappa and delta are there as well. I'm not going to really cover these too much, but just know that they can have some different activities. Some actually cause dysphoria. Some are good for issues of neuropathic issues, but we're just going to focus on the mu. So big differences between the agents we're going to cover probably the next time we meet is that you can have full agonists. You can have the drugs that are going to be fully active at the site. You're going to have drugs that are partial agonists, which only kind of partially activate those receptors. And then we're going to have antagonists. So what cases do you think we might use an antagonist? So if you have someone who's got too many opioids on board, you can reverse it, right? Anyone know what we use to reverse opioids? Naloxone or Narcan, right? We're going to talk about that later. So it's important to know the antidote for these agents because, again, you can potentially save a life if you can give this in the right time frame. When you might use a partial agonist, like what's the point of having only partial effect on those receptors? Mm-hmm. Absolutely, yeah. So we'll talk about one agent in particular called buprenorphine, which is good for patients who are addicted to opioids who are trying to get off of them. So if I have something that is kind of just partially activating the receptor, because what does that do for those opioid patients? What are we trying to prevent? Well, yeah, so right, but the big thing you want to prevent, because why can't people just quit opioids cold turkey? Withdrawal, yeah. So that's the big thing, is you want to stave off withdrawal, because as soon as you withdraw, especially people going cold turkey, like they're much more likely to relapse and go back to the medication that they were, or the substance they were abusing. So you're trying to prevent that. So that's where partial agonists are going to come into play, and we'll talk about that later. But the agonists are going to be the most commonly used. So you think morphine, you think fentanyl, you think methadone, those are all going to be full agonists that we'll talk about in more detail probably soon. Let me just finish this section up here. As far as terminology goes, when I say physical dependence, what do you think that means? Yeah, so these are people who, homeostasis is something that occurs when in response to these drugs where they get very used to having the opioid effect around, and when they stop taking the medication, they will have physical withdrawal effects from that, right? Because the body has now gotten used to that and needs to have that drug around to maintain kind of the normal function. Is this the same as addiction? No, just because you can be on opioids for years for your chronic pain issues does not mean you're addicted. Now, if you come off of those immediately, you're definitely going to go into withdrawals, and that's definitely physical dependence. However, that's not addiction. Addiction is going to be basically where you're continuing to use the drug despite negative harm. So if I'm continuing to use it despite the fact that I can't afford food to feed myself, or I'm not taking my kids to school, or I can't keep a job, that is that negative use. I'm continuing to use it, but despite that, that's addiction, right? So it's important to kind of keep the delineation there. Keep that separate, because you don't want to treat every patient who has physical dependence like they're addicted. However, most of those addicted patients are going to have physical dependence there. When I say tolerance, what does that mean? Yeah, so the euphoria effects or the analgesic effects tend to go away with time with that same dose. So I have to keep kind of chronically ramping up my dose. So if you had a patient comes in and say, hey, man, that stuff you gave me is just not working anymore, it could be someone drug seeking, but a lot of times it could be someone who's just having that tolerance develop where they have to increase that dose in order to achieve the same analgesic effect. So that is another common phenomenon. And we'll also talk about pseudo-addiction kind of very briefly, but those are the main terms to kind of keep in mind: that physical dependence, right, that addiction, the difference between those two, and then the tolerance that develops. Because you'll find that you'll get tolerance to the analgesic effects, but you really don't get tolerance to a lot of the side effects. So the constipation that's you see chronically with these, that never goes away. The respiratory depression effects never goes away. So you got to be really careful with that, because as you increase those doses, patients are going to have more side effects just to keep the same kind of analgesic effects that they're looking for. Right? So pseudo addiction is going to be basically where you have someone who appears like they're addicted. Say, for instance, like they say, hey, you know, that stuff you're giving me was working, but now it's not. I need more drug, or they run out early, or something like that. Things that would appear to say that they're self-medicating. But for instance, like what if their pain actually got worse? Like what if they're doing something something has changed where they have more pain than they had before? They're not being treated appropriately anymore. So it appears to be addiction, but not really, right? And so again, those can be very difficult to ascertain in the patient because again, especially in the tox world. You know, we know patients are lying when their lips are moving, essentially. So it's very difficult to take people at their word. But we said e-force before. I encourage all of you guys to sign up for this as soon as you get a license. It's very, very helpful to look up your patients to see like where have they been filling opioids before. This is a state. Every state has a different program, and we're kind of late to the game getting this one. But you can sign up for it. Any healthcare provider and pharmacies have to report this up, saying what opioids they're filling. So you can, you know, if a patient comes in, they're saying, hey, you know, I ran out of my pain medications early and I really need something. You can look them up to be like, okay, well, you filled 200 pills at, you know, 5 different pharmacies in the past 5 days. Can you explain that? You know, that's hard to refute that, right? Versus if it looks like they have very legitimate, they haven't filled for a month, maybe something actually, you know, looks legitimate, you can say, okay, well, I'm more likely to prescribe for them now. So those are things to keep in mind, and that can be very useful to look up that information. Okay, so that's it for today. Any questions? I'll get the test validated, see if there's any givebacks or anything like that, and I'll post an announcement later. Otherwise, I'll see you guys next week. Thank you.